Great to have you all here. And thank you very much once again for being part of this webinar. So the structure that we had thought of was to have a brief introduction about atrial fibrillation and ventricular tachycardia and other kinds of arrhythmias that patients face. We will be joined shortly by Dr. Niraj Varma and Dr. Tamanna Singh, but I think we can get started. So we're also very fortunate to be joined by three esteemed panelists who have all used the Frontier X2 and the Frontier X Plus devices in the past, and who have all had sort of life-altering experiences, in the course of their own medical journey, and somewhat where the Frontier X2 device played some role in their diagnostic and treatment protocols. So actually, maybe I'll first invite David Hayford, who lives in Florida, is retired now, and has been doing triathlons for the last 10 years, to talk briefly about his experience and what led up to the event that he had in 2021. So David, I'll first turn it over to you.
Thank you. Good morning. I'm the amateur here. I was a chief financial officer of a number of companies, and in my 50s, started to get back into shape, and started out by running, and then my two daughters were running half marathons, and my oldest son out in California was doing full triathlons. And so I added in 2018, when I was 62, I did a metric century bike ride, a half marathon with my two daughters, and then a sprint triathlon up in Chicago. And then I retired and moved to Florida. And in 2019 and 2020 was getting serious to do a half Ironman. And on a training run in March of 2021, it wasn't quite going right. I had a little indigestion, thought it was probably just my acid reflux acting up. Powered through it for my morning run, and 10 hours later, essentially died of a sudden cardiac arrest. Fortunately, my wife was right there and gave me CPR for 12 minutes until the EMTs got there. They took me to Cleveland Clinic, where fortunately they, during COVID, had a breather available. They had some kind of an ice set up to save my organs, put two stents in, and a couple of days later I came to and had survived it. It took about a year before I was back into training, thinking I was fine. And my son gave me a Frontier device for Christmas, and it kept on zapping me when I was playing tennis or when I was on my runs. And being pigheaded, I put up with it for a couple of weeks, and then went to the ER, and they discovered that both of my stents had failed, and I needed a quadruple bypass. And that went very smoothly, and I'm back. I'm here, and moved my cardiologist from here to Florida. I commute to Cleveland once a year because if I'm doing this stuff, I should have a sports cardiologist who actually understands all these proclivities of people who do these things to their bodies, and supports heart health and being able to run and do things like this. I turn 70 next year and hope to be back in full swing. And I wouldn't do a long run without a Frontier on me. So if something feels weird, I can send the information to my doctor.
Thank you. Thank you for sharing that, David. Really interesting experience that you've had. And we will show the, what the device looks like and how people can use it in a short while. But before that, actually, we now have Dr. Tamanna Singh. Can you hear us, Dr. Singh?
I can. Hi, everybody.
Hi. Thank you. Thank you very much for joining. So, just a brief introduction to Dr. Tamanna Singh, who also happens to be David's cardiologist. So, Dr. Tamanna Singh is a clinical cardiologist and the director of the Sports Cardiology Center at Cleveland Clinic main campus. She earned her medical degree from Boston University School of Medicine and served her residency at Boston Medical Center. She served a 3-year fellowship in cardiology at the Icahn School of Medicine at Mount Sinai, and then returned to Boston to complete her specialty training in sports cardiology with the Cardiovascular Performance Program Fellowship at the Massachusetts General Hospital. She has a special interest in sports cardiology and cardiovascular care of competitive and recreational athletes, which is why I think she probably has a lot of insights for a lot of our viewers today. And she has research interests in comparing the effects of plant-based diets versus an all-inclusive diet for heart health. And she's published several research papers in medical journals on exercise, sports, and the heart, and has presented at several national medical meetings. So, Dr. Singh, I'll turn it over to you to discuss. I'll just lay out some of the questions that a lot of users and viewers in this webinar have. So first, what kind of exercise-induced arrhythmias can a person have? And what is the global incidence of exercise-induced arrhythmias? Secondly, what kind of symptoms should you look out for to determine if you have any worrying arrhythmias? And thirdly, what is the value of monitoring ECG during exercise? And what kinds of data do sports cardiologists look for? So I'll just turn it over to you, Dr. Singh.
Wonderful. So in terms of the global incidence of arrhythmias, I mean, we have so many arrhythmias, whether they originate from the atrial chambers or the ventricular chambers, it's really hard to capture all of them when it comes to exercise. When we're thinking about arrhythmias, the way I like to talk about it with patients is considering what is benign and not really going to impact participation in sport or participation in exercise, and what is more malignant and could certainly have a role in how much we're actually able to move our bodies. The number one arrhythmia as we age in particular, and even in athletes, tends to be atrial fibrillation, with age being the number one risk factor. And when we talk about it in the athletic scope, we do know that individuals who are sedentary or who are a little more active can actually have a reduction in intensity and frequency of AFib with more exercise. But there seems to be this bit of a paradox at probably around 1,500 to 2,000 hours per week, where we can start to see maybe a little bit of a rebound and a potential shift in increased risk of developing AFib as an athlete. But that being a relatively benign arrhythmia is not something that would tell us, hey, you really shouldn't exercise now that you've had an episode or two of atrial fibrillation. But it is one of the more common things that we encounter in our texts. In terms of more malignant arrhythmias, we kind of start with some isolated beats of premature ventricular contractions and kind of see whether or not those are things that degrade and increase in frequency with exercise. The way they look, how they appear, how often they appear can have implications on what we need to do in terms of downstream testing with respect to investigating the cause. Could it be cardiomyopathy? Could it be a primary electrical disturbance? Could it be ischemic heart disease? Could it be related to congenital abnormalities in a younger individual? And then finally, we have our kind of sustained ventricular arrhythmias, or things that can really be brought on by exercise. And we do know that these are certainly things that we can find in individuals who have familial cardiomyopathies or some channelopathies or electrical insults that are precipitating this nidus for malignancy that can certainly transgress into sudden cardiac arrest and death. And how do I counsel athletes when they come to me and say, wow, the electrical wiring of the heart sounds really scary, and what am I at risk for? If I do intense exercise and my heart rate goes to 160, should I be afraid? And the way I typically counsel is, let's actually see, what's going on. And athletes who are symptomatic are probably, relatively easy for me to evaluate. I can stick them on a treadmill or put them on a bike and hook them up to an EKG. But oftentimes in that very isolated 8 to 12 minute setting, we may not manifest what is precipitating during their regular day-to-day training. And so when we think about ambulatory rhythm monitoring, we have multiple devices that can sometimes be helpful, but typically tend to be short-lived, from a day to 3 days to 14 days to 30 days. And so time of capture is still, something that can limit our ability to diagnose. And I think that kind of, one way I can transition into, how we can do long-term monitoring and ECG monitoring in athletes with devices like the Fourth Frontier, where, I can have individuals like David or my other patients who say, "Hey, doc, I get symptoms, palpitations, or, I pass out with exercise on these occasions, not all the time." They can easily wear something that captures their good quality EKG data as well as their training capacity, their intensity, their heart rate, and easily upload it for me on that day. So it's very timely evaluation and honestly is more efficient way to diagnose malignant arrhythmias. So I think that's kind of the value. And, at the end of the day, I think EKG monitoring is not meant to be, a way to find something. It's really a way to be supplemental and investigatory when we're thinking about how to, evaluate symptoms. And common symptoms I see in my office, particularly related to exercise, are some of those that I've described, like chest discomfort or chest pain, difficulty breathing, which is, a little bit hard to describe. The way I like to describe to my patients is there some discordance in your shortness of breath with relation to your exercise intensity. So are you jogging at a really easy pace, and is it suddenly becoming really difficult to breathe? Certainly, exercise-induced presyncope or syncope, losing consciousness with exercise is a huge red flag for us, and certainly palpitations coming on with exercise is something for us to investigate. So people present in all different ways. Our job is to really kind of put our detective hats on and see what's concerned and what's not. But, I think monitoring the frontier, particularly in my practice, are incredibly helpful. Like I mentioned, it just makes my way of practice very efficient. It provides and empowers my patients with a tool that they can reliably use and share with me. And oftentimes we can either provide reassurance or we can truly diagnose something that could be harmful and deal with it.
Thank you. Thank you very much for that overview. I think we have a couple of, very high endurance athletes on the panel in Brian and Ron, who will share their stories in a few minutes. But before I turn to them, and I think they'll be able to, also relate their experiences with what kind of symptoms they faced and how they were able to diagnose their particular issues. But before I turn to them, let me welcome Dr. Niraj Varma onto the panel. Dr. Varma, can you hear me now?
Yes, I can hear you. Thank you. Good morning. Good morning, everybody.
Thank you, Dr. Varma, for joining. And to give a brief introduction to Dr. Varma, Dr. Varma is a staff physician and the head of the Holter Lab in the section of electrophysiology and pacing at Cleveland Clinic main campus. He specializes in the treatment of heart arrhythmias, and he has a special interest in ablations for atrial fibrillation and ventricular tachycardia, as well as defibrillator implantations and biventricular pacing. Dr. Varma earned his doctorate in medicine from Oxford University and a Bachelor of Surgery from Edinburgh University in the UK, where he's a fellow of the Royal College of Physicians of Edinburgh, London. In a career that spans nearly 3 decades, Dr. Varma has published hundreds of articles on pacing, arrhythmias, and electrophysiology in leading peer-reviewed medical journals. He's the author of a textbook on electrocardiography and of numerous chapters in other textbooks related to his specialty. He's also a dedicated researcher who has received grants from the American Heart Association, a National Research Service Award, as well as industry funding for studies of innovative technologies. So without further ado, I'll turn it over to Dr. Varma to discuss, in particular, some questions that are of great interest to our audience. So firstly, just an overview of what atrial fibrillation is and what risks it poses for the health of someone who's been diagnosed with AFib. And what is the importance of measuring the burden of atrial fibrillation and how this might inform the treatment decisions that the cardiologist would take. And thirdly, what is the importance of monitoring ECG continuously for patients with asymptomatic AFib in particular? So I'll turn it over to you, Dr. Varma.
Thank you, Dr. Bhushan. Thanks for the very gracious introduction. The list of questions that you've asked will probably take a 2-day symposium to answer in completion. But atrial fibrillation is very common. It accounts for probably 80% of our work in electrophysiology just now in one way or the other. And the way it manifests is very different. It's a very prevalent condition, and it can cause patient morbidity. And they may not have palpitations because 80% of atrial fibrillation events are asymptomatic, which makes it hard to track down via symptoms alone. And often patients don't have palpitations, but they feel the other effects of atrial fibrillation. They might feel tired, they might feel short of breath, they might attribute that just to aging or being out of shape, but it might be atrial fibrillation. Ultimately, this accounts for a great deal of presentations to primary care physicians, to emergency rooms for treatment. And that's when atrial fibrillation is diagnosed, really when it comes to a critical point. The other way it can manifest is with heart failure. That is a concern. So there's a large amount of overlap between atrial fibrillation and electrical abnormality and heart failure symptoms. Unfortunately, it can also present with a neurological problem, which is a stroke. And that often is a more severe kind of stroke. AF-related stroke is more severe than general strokes that occur in the community. So that is something to avoid. So hence, we're beginning to monitor for atrial fibrillation very aggressively and also treat atrial fibrillation very aggressively. It's an epidemic in our cardiology world just now. And the risk factors are usually age and hypertension. So that is what atrial fibrillation is: electrical disorder of the top chambers of the heart, particularly the left atrium. And in the last 20 years, we have discovered ways of treating this and produce cure. So rehabilitation strategies are rapidly overtaking drug strategies for restoring normal rhythm and keeping people in normal rhythm. And there are significant randomized trials that have shown that keeping people in normal rhythm improves their well-being and reduces their hospitalizations, improves their general outcomes, reduces heart failure as well, improves survival. So this has become a very important therapy for us. But as I said at the beginning, 80% of atrial fibrillation episodes are asymptomatic. And we don't want to wait until the patient presents with a critical event, because by that time, often it's too late to address the situation. So hence, there's a great deal of emphasis on monitoring. So when patients have symptoms that might be attributable to atrial fibrillation, we monitor them. When we treat patients with fibrillation or an anterior or rate control, we monitor them. When we have patients who have implantable devices, for instance, pacemakers or ICDs, those devices provide continuous monitoring and give us that information, but it's a very small segment of the community. So most patients don't have implantable devices. So there are two options for monitoring the general population: to look for atrial fibrillation, screen for atrial fibrillation, or to monitor treatment. And one is precise therapies like a Holter monitor, which we've used for literally 60 years, or more recently, patch-based monitors. And these are prescriptions. They follow a medical routine, but they're really only for finite periods. A Holter monitor may be for 1, 2, or 7 days. A patch monitor for 2 weeks. There's no extended monitoring. So this really just gives us a small snapshot. And atrial fibrillation, as we know, is very, very sporadic. It may not occur for several months, and then it suddenly might occur very intensely or even continuously. So the issue is monitoring for extended periods of time. Wearables provide that ability. We have indefinite length of monitoring, and patients can activate this themselves. And we have watch-based monitoring, We have electrode-based monitoring. So these have changed the landscape for both screening for atrial fibrillation and monitoring treatment for atrial fibrillation. So patients can self-monitor. And an increasing number of patients, not really patients, but people who felt unwell and bought a consumer-grade device and found an arrhythmia present to us, and then they become patients. So self-discovery. So I think wearables have really changed the ability for us to track atrial fibrillation, discover it, and then track treatment. The issue with those kinds of monitors is that it is intermittent, it is patient-driven. So if they don't monitor themselves every day or once a week, then you're only having a snapshot again. So here the benefit of continuous monitoring comes in. And if we can monitor continuously, then we can track atrial fibrillation much more accurately because we know it occurs intermittently. And there's increasing importance attached to the burden of atrial fibrillation. That means how many hours in a day, how many minutes in a day a patient may have atrial fibrillation, and how atrial fibrillation days cluster together, because the intensity of those episodes might actually increase the risk of stroke. So this is an active area of interest of research. At what point of atrial fibrillation burden is it mandated to intervene with therapy? Just now, the indication for therapies are to improve patient well-being and prevent heart failure and prevent stroke. So those are the imperatives for atrial fibrillation treatment. But the burden of atrial fibrillation that triggers those treatments is still being investigated. And the ability of continuous monitoring gives us that opportunity. And I think the fourth frontier device really enables us that way.
Thank you. Thank you, Dr. Verma, for that very detailed response. And I think we have a few questions from some of the participants, which I will put to you in a little while. But just to give everyone a sort of visual glimpse of the device that we're talking about. So this is the wearable device. This is the Frontier Plus, which is FDA approved for long-term continuous monitoring of your ECG, and which also is able to detect atrial fibrillation, tachycardia, bradycardia, and other arrhythmias in real time. And to give you a very quick sense of the kind of data that this provides, so this device goes on to a chest strap of this form. The strap is similar to what you may have seen with the Polar and Garmin heart rate monitors. It goes around the chest and it has these conductive silicone-based electrodes on the back, which are in contact with your chest. And we are able to show, we're able to firstly record and live stream your ECG. So as you can see here, I've put on the device and I'm able to live stream my ECG. And I have a few colleagues in the office who are also live streaming their ECG. So it's able to record a high quality single lead ECG, which is what was used by Ron, David, and Brian, who are on the panel today to diagnose their medical conditions or to provide inputs to their cardiologists to help diagnose their medical conditions. But we'll go through a more detailed demo of the capabilities of the device a little later on. Right now, I'll turn it over to Ron, who is also a retired triathlete and who was actually diagnosed with AFib in 2024. And I'll turn it over to Ron to share his story and to share, how his diagnosis was done and the treatment that followed thereafter.
Well, thank you. Yes, I am 81 years old. It's hard to believe that so many years have gone by, but my business career was in developing medical office buildings. So I love being around doctors, so I appreciate Dr. Singh and Dr. Varma's perspective. Certainly have a lot of questions for them myself. But I'm living in North County, San Diego, kind of the home of Ironman triathlons. I was telling Brian and David earlier that Mark Allen, Dave Scott, um, all of the 80s triathletes lived in North County, or a lot of them did. And so I got exposed to triathlons and started when I was in my late 40s, early 50s, in the 80s. And consequently, as time went on, I got involved in other aspects of reinventing myself, as it were. But as Manav indicated, in late 2024, I went in for cataract as opposed to cardiac cataract surgery, and part of the protocol is having a complete EKG, in which case I was diagnosed I had tachycardia, atrial pauses, and that sort of thing. So subsequently, in February of this year, I had a Medtronic AV2 and a Watchman uh, procedure implanted. Unfortunately, I had pericarditis subsequently, and I went through hospitalization and a number of things. As a result of that, I ended up getting a Frontier X2 monitor because I wanted to get back into shape after being hospitalized and bedridden and so forth. So subsequently, I have, as Dr. Varma indicated, uh, utilized a number of tools, not the least of which is the Frontier X2, in conjunction with a Zeo patch monitor, which I recently had, just to confirm some of the indicators that became evident from the Frontier X2. And also at the same time, utilizing data from my Apple Watch. So between these wearables, I've been able to get an overall picture for my electrophysiologist in terms of determining whether I should go ahead with a Farapulse procedure, which would be yet a third procedure. What's unusual is that based on these devices, my burden has gone from 0 to 98 time, and now based on the latest Zeo patch, I'm at 36%. So my rhetorical question is, should I get this Farapulse procedure, or should I kick the can down the road for later symptomatic symptoms? Right now, I have been totally asymptomatic and don't exhibit any of the symptoms that are typical of either bradycardia or tachycardia, which is lightheadedness, fainting, and that sort of thing. So that's my patient's perspective. I'd appreciate any of the doctor's comments or thoughts from their perspective.
Yeah, no, thank you for sharing that. That's very interesting. Very, very interesting. So I'm glad that you had interaction with doctors professionally, but I'm sorry you're having interaction with them now medically. If you have no symptoms, that is a good thing, but it doesn't take away the damage that atrial fibrillation might be doing. So continuous atrial fibrillation can affect the atrium. And one of your questions was kicking the can down the road. What we are finding is earlier intervention is more likely to produce cure. Because the longer you leave atrial fibrillation, even if you don't feel it, the more likely it is to cause irreversible changes in the heart, both in the atrium and in the ventricle. So our thinking now is to move earlier and earlier with the intervention. And 36% atrial fibrillation is a significant burden, even if you're not feeling it. And the natural history of that is simply to increase. It doesn't go down. In patients who have intermittent atrial fibrillation, it comes in clusters, and those clusters begin to increase in frequency, so the time spent in normal rhythm in between goes down, and then atrial fibrillation takes over. So the natural history is for that to progress. And the longer you stay in atrial fibrillation, the more likely it is that it'll become irreversible. The good thing is you're not feeling it, but when it becomes irreversible, you might feel it. That's not a certainty, but it's a possibility. And what we found is that many patients claim that they don't feel it, but when we restore normal sinus rhythm, they feel better. So I think because it's a slow progression of symptoms, people don't feel it. It's not a change from one day to the other when people would feel it. But once we restore normal sinus rhythm, they feel it. They feel the difference and they feel back to baseline. So that is the way we're thinking just now. Earlier intervention is better.
Thank you.
Thank you, Dr. Varma, and thank you very much, Ron, for sharing your story. I think it's representative of many of our users and patients that we interact with on a daily basis. This question of when to intervene, or especially when to go in for a invasive procedure, is something that is a key question for a lot of patients who are suffering from atrial fibrillation or other kinds of arrhythmias. And of course, Varma at the cutting edge of this field, which is constantly evolving. So, we will also do our best to convey the latest research to other users like yourself. But once again, thank you very much for sharing your story. I'll now turn to Brian, who had a similar kind of experience. I would say perhaps even more life-threatening when he faced an episode of ventricular tachycardia a few years ago. Brian is a 10-time Ironman athlete. So yeah, Brian, over to you to share your story.
Hello, everybody. Dr. Singh and Dr. Varma, really good to hear your perspectives and to be here in this community. It's never alone. I have a fairly high level athletic career. I started when I was 8 years old as a national level swimmer. I'm now 54, and throughout my career, I did World Championships at an Ironman in Hawaii, and I've done hundreds of ultra distance races, from 250-kilometer runs across the desert to Ironman, and always fared as a fairly high level elite amateur, not a professional. But interestingly, I was having some trouble breathing back in end of 2023, 2024, and I discovered that I had a large ASD, atrial septal defect, which was huge. It was 22 by 28 millimeters, and I had a 2-to-1 left to right shunt. So it was having a lifetime career as a good athlete with a hole in my heart that was congenital. And I knew I had it when I was a kid, but I grew up in East Africa, so we didn't really get it checked again. So it was a long-term problem. I had it closed in Cleveland Hospital in Abu Dhabi, where I was living at the time, and my recovery was pretty quick. I was within a few weeks of surgery, I was back moving again and climbing stairs and cycling, and pretty quick back to no use of drugs. So bisoprolol, I was down to 1.25 milligrams and then off it within 3 months. So I had nothing left remaining, but and I'm a physiologist, excess physiologist, so I sort of rehabbed myself back, and didn't see anybody else with regard to what was happening. I did get a heart rate monitor. I did get the Frontier X2, and in November 2024, I was out cycling on a 3-hour ride, it's not significant for me. I was in Morocco. I travel a lot for my work, and it was a hot day. I hadn't drunk so much water, and I suddenly sort of felt strange, pulled my bike off the road and hit the ground. And I was conscious, but in a lot of pain for about 9 minutes. And then got back on my bike and cycled home, and I found that I was in ventricular tachycardia for that time. So I basically went into complete ventricular tachycardia. As an athlete, we often overlook these things as being a bit of a bug, something that wasn't important. But when I went to see my cardiologist in my cardiologist in Spain, they were able to, they were obviously able to look at the data that came from the report and see that I was in this VT for 9 minutes. It was an incredibly painful experience. I thought I was dead. I thought I was dying. But I was still conscious, and I was still standing up. So for some reason, my heart was, even though it's a VT, it was still, some blood was being pumped around, and my organs and my brain was still functioning. I didn't move unconscious, and if I had, I wouldn't have survived, because there was no one around me that would have been able to help. So that's why I got on my bike and cycled home. And then later that year, I had ablation surgery, because they found that there was a section that was causing the VT on the lower part of my ventricle. So I had ablation surgery, and since then I've been and used the Frontier X2 to come back to a reasonable level of function. My VO2 max when I was in my 20s was about 72. Now it's in the early mid 30s, but I know I can build that up again. It's just in terms of function, I'm putting a lot of my data through AI. When I the reports, I've had also some interactions with the team, the cardiac team at Fourth Frontier. It's been amazing data for me as a physiologist to review. Obviously, I'm not an expert in cardiology, but have picked up a lot, having been through the ASD closure, and having sort of found myself in this space where I'm referring a lot to my data, tracking my training, taking really taking care of what I'm doing with my training now. As an athlete in the early days, we just train as hard as possible. But now I'm really taking really taking notes of where the recovery is, where the zone 2 is, what I'm doing in terms of high intensity, what the recovery is, what the heart rate looks like. I'm not wearing the monitor all the time, but it's been very helpful to draw out the PDF files, put it into. I keep one log on AI that I discuss every time I have a session. And so I have 20 or 30 sessions that I've tracked on AI. So it's been very useful. Yeah, and that 9 minutes is something that's sort of a recognition of our vulnerabilities to one day that it will be it, and for me on that particular day, I was surprised that was the end, and wasn't, thankfully.
And you've had no current VT, correct?
Not as far as I'm aware. I mean, I sometimes have breathlessness. I think it's because I'm not able to calm down after sessions. I think that my flexibility between exercising and relaxing, with a lot of athletes, the vagus nerve seems to be overstimulated. So I'm doing some work on the vagus nerve. I manipulate it in my neck and my stomach, and that seems to help. And also doing breath work. I track this on the monitor, and when I do, before I go to sleep, I also do a bunch of breath work. So I think in athletes, the challenge is that we are often in this sympathetic state, and we forget to go into parasympathetic, or we forget to practice that state of going into parasympathetic through either breath work or meditation or other form of non-pharmaceutical relaxation, taking the body into a state of rest and digest.
Well, thank you very much, Brian, for sharing the story. And with your permission, I've also brought up this particular recording of the fateful day that you're talking about. So with your permission, I'll bring that up so that people can
Yeah, sure. Of course. That's fine.
and then I would actually also, so let me just show everyone what Brian is talking about here. So this is the 3-hour cycle ride that Brian is talking about, which he did on the 2nd of November, 2024. And as you can see here, he's in normal sinus rhythm, though with a few ectopic beats. And this is a question that I'll put to Dr. Tamanna Singh after this, that, what are the signs that highly trained athletes and regular folks like me should look out for before we have an incident like the one that Brian had? Are there signs that one can look out for, or are there symptoms that one can look out for? But in this particular recording, you can see that Brian's heart rate was going up. He had fairly frequent PVCs compared to most people, though not something that you would call worrying, at least to my knowledge. And then at this point, yes, here you can see that the rhythm suddenly changes from normal sinus rhythm to what was diagnosed by Brian's cardiologist as a run of ventricular tachycardia, which lasted for a full 9 minutes, as he mentioned. Right? And at this point, reverts to normal sinus rhythm.
Yeah, it's an incredible tracing. I mean, you have PVCs and CTT with a different morphology, and it's going at 300 beats per minute. So I'm highly impressed, Brian, that your physiology could cope with that and you retained consciousness.
Yeah,
Yeah,
I
it
mean,
was very painful. Very painful.
I think from kind of sports cardiology lens, this is certainly what we don't want to see happen with exercise. And when we're thinking about quote unquote signs or symptoms to look out for, it certainly can be hard. I mean, it sounds like, Brian, you really didn't have any reason to think that this ride was going to be different from any other ride. And oftentimes this is how sudden cardiac arrest and death presents, unfortunately. When we think about, what tools we can put in our toolbox going out for rides, whether they be easy or runs, whether they be intense, I think the first thing you really have to understand is what is your medical history, and what is your family history, and kind of understand that clinical context. It certainly gives us as physicians a little bit of insight into, are you an individual who somehow has elevated cardiovascular risk, whether it be for certainly familial issues or genetic issues, or in our masters athletes, heart disease. We're not immune as athletes from high cholesterol, high blood pressure, abnormal blood sugar management, and we have to be and hold ourselves accountable to do all of that annual monitoring to see what is our cardiovascular risk. Because heart disease is very easy to manage, and it's very easy to prevent some of those events that can occur when you have obstructive disease or an acute coronary syndrome. I think the familial or genetic issues can be a bit more challenging, particularly if you don't know your family history. For our younger athletes, less than 35, 40 years of age, this is the cohort where we do see people manifest sudden cardiac arrest. And if a defibrillator is not around or people can't perform CPR, it certainly can degrade into death. This isn't meant to scare anybody, right? I see athletes that are post-pubescent all the way to, 86, 87, 89, 90, fully functioning. But I think, the things that we certainly can do are, when we're leaning into movement, being mindful of how we are going into that. Brian alluded to several factors that he's now incorporating in his athletic practice, which include rest, recovery, and understanding intensity and what that role of intensity or ease plays in your training cycle. And going into your workouts and into your races, into your higher efforts, well hydrated with appropriate electrolyte repletion, well fueled, adequate nutrition, and well recovered. It's not to say that that's going to prevent things from happening, but it can certainly hopefully lessen the likelihood. Um, I get I will say my eyebrows get raised when people tell me that they're having a lot of exertional symptoms. One thing that I think can sometimes be challenging is when individuals say, I start a ride or I start a jog and I start to feel maybe some chest discomfort, maybe some difficulty breathing, but after a couple of minutes, it kind of goes away and everything feels great. It's hard to distinguish whether that's just truly body warming up and you're getting on your ride, your run and feeling okay, or could that be something that we describe as warm-up angina, where you actually have heart disease? It takes a couple of minutes to recruit these vessels called collateral that have developed over time, provide oxygenated blood flow to the part of the heart muscle that's just not getting good flow from your larger vessels you're born with. That's just one example. Other examples are when individuals say, I'm feeling more palpitations with exercise. That to me starts to get me thinking, are you having an arrhythmia? Are you having premature beats that are through that workout increasing in intensity and frequency, which is a bad prognostic sign? When people have early beats at rest that tend to go away with exercise, it's actually quite reassuring, though I still typically will do my due diligence in ensuring that structurally and functionally the heart's looking okay, and electrically we don't have any major disturbance with exercise. And then certainly, any sort of chest pressure, chest discomfort, neck discomfort, or difficulty breathing, again, discordant to exercise intensity, passing out while you exercise, those really are the big red flags. So anything with exercise that one is a gut check for you that something is not right is when you should certainly reach out to someone like me to say, hey, this is what my training looks like. This is what my clinical history is. This is what my family history is. And this is what I'm feeling. And then from there, we can start to develop a plan of how we can get down to the bottom of what's going on.
So one question, Dr. Singh. Brian said he had a cardiac intervention before. So what's your recommendation for people who've had structural heart disease or post interventions in surgery regarding resumption of exercise?
Yeah, for the most part, we really try to advocate for incorporating exercise just because over time, the number one killer is heart disease. And so, to tell someone, hey, just because you've had open heart surgery, or you've had a closure, venous closure, or, whatever sort of treatment, that's not enough reason to say you shouldn't exercise. And unfortunately, I think that comes from a lot of physician bias when you're not taking care of individuals who are so high functioning and so ingrained in exercise, and that's part of their quality of life. And even in our individuals who are sedentary and trying to build a fitness program, it's incredibly important for us to support that. I think the answer to your question is it depends. It depends on what the actual inciting issue is. Run-of-the-mill coronary disease, bypass surgery, interventions with stents. We want individuals to, enroll in cardiac rehab, which is a dedicated exercise program. We monitor heart rate, heart rhythm, blood pressure, and essentially do a graded protocol to return to level of fitness. That being said, a lot of my high functioning athletes supplement their cardiac rehab with building that protocol on their own. And so we want people to exercise. Exercise is good for the heart. It helps it become efficient. It helps with collateralization. It helps that pump stay strong. The situations where it can get a little tougher when we have individuals with cardiomyopathy. So something's intrinsically wrong with the heart muscle. So things that might be common for our viewers, hypertrophic cardiomyopathy is something many people hear about, thickening, abnormal thickening of the heart. Arrhythmogenic cardiomyopathy or arrhythmogenic right ventricular cardiomyopathy, when we have fibrofatty infiltration of that right ventricle, which can precipitate electrical disturbance, particularly with higher volume of exercise and higher intensity exercise. We have dilated cardiomyopathy. We have infiltrative disease. So there's so many things that can go on with the heart. But there's really very few issues with the heart where certainly, hey, we need to start having a conversation of, what does exercise mean to you? What does athleticism mean to you? And in the context of, this disease process with X amount of risk and X amount of harm, how can we still incorporate movement practice within the confines of this particular pathology? That's where shared decision making really is the cornerstone of what we do. But few and far between pathologies, I would say, where we we counsel on potentially really minimizing the intensity of exercise and focusing on something that's lower intensity for lower risk. But it really depends.
Can I make a comment on that, if I may? Regarding Brian's experience at 54, and I'm aware of a number of ex-pro triathletes in North County, San Diego, like Scott Tinley. Mark Allen is the person that has a different type of training approach as opposed to high intensity all the time. There's been a number of Ironman triathletes, as Brian knows, Dave Scott, Scott Tinley, Rock Fry, that are high intensity trainers that have had open heart surgery. Is there, Dr. Singh, a approach to level 2 training as opposed to high intensity all the time, particularly relative to utilizing devices such as the Frontier X2?
Yeah, certainly. I mean, we do know that higher intake exercise, again, the number is very small. Higher intake exercise can precipitate some cardiovascular unfortunate manifestations, but that number is supremely small. And again, it really depends on the context of the individual. In terms of polarized training, or I should say training perhaps in one focus, so high intensity versus zone two, again, I think it depends, what is your aim? What does your training cycle look like? When I typically counsel my athletes, I actually do enjoy kind of more polarized training. I think there's a huge role in your aerobic base building and build your mitochondrial density and certainly your capillary density, right, to help really optimize oxygen delivery to your muscles and get your heart more efficient. But then there's certainly a role for doing, threshold work, a very small amount of VO2 max work if you're looking to really push the speed, push your anaerobic capacity, and build up that power and strength. So, it again is kind of a conversation with the athlete on what their goals are. But I typically will counsel on really having a very robust base. And then, sprinkling your intensity, sprinkling your more focused training to get those goals that you're trying to hit, particularly when it comes down to time and power and speed and whatnot. Um, and then in terms of the role of the fourth frontier device, I think it's excellent for individuals who are looking to use a zone model or heart rate training. I think as I kind of age, as a physician and an athlete, I think I push probably leaning into effort a bit more. I think effort keeps us honest and holds us accountable. But there's, nothing wrong with leaning into heart rate training zones, particularly if you are doing a stress test for doctors, and we're noting that there's some potential irregularity or regular beats or early beats or maybe some non-sustained arrhythmias at particular heart rate threshold. I think that's where heart rate zones can be helpful, and the device can certainly hold people accountable to that. And then when you are doing intense efforts, I mean, this is the perfect device to, hopefully build reassurance, alleviate some anxiety, and certainly, help build that confidence and performance when you're doing those high efforts and noticing that from a rhythm perspective, the data looks quite clean.
Thank you. Thank you, Dr. Singh.
May I just add one question, please, Dr. Busher?
Please go ahead.
Sorry, I know that we're coming to the end, but it's a real quick one because the algorithm obviously for the Frontier X2 is measuring me at a low VO2 max, and I know when I put the numbers into the actual, like an AI, as my actual raw results, so speed, height, if I'm climbing, if I'm doing a cycle of 4 hours, I put this into the data, but the algorithm for the X2 is showing me quite low. So it shows my VO2 max is not higher than 32. And I know for sure that I wouldn't be able to do any of the things that I'm doing if it was anything under 40. And as I said, when I was in my 20s, my VO2 max was in the high 60s. So is there something that is in the algorithm that is underestimating, or is that a model, or is it something that is just a part of because I mean, an athlete a longer time, the heart is not the only thing that will show the VO2 max. It'll also be the capillarization and the function of the body in dealing with that state of intensity?
Yes, so let me answer that. I mean, the VO2 max value that is being displayed on the Frontier X2 is a wellness metric which is derived from the heart rate and the heart rate variability. So it is a ECG derived estimate of your VO2 max. It's definitely not a substitute for VO2 max that's measured in a lab with a CPET machine or the gas mask. So we do, I mean, the algorithm does allow a user to input a measured value of VO2 max, which then serves as a calibration, which then correlates with their heart rate and heart rate variability, and then provides more accurate estimates going forward. But yeah, so in your case, Brian, it's likely that it's underestimating the true value, and I would recommend an actual VO2 max test in a CPET lab to calibrate the value. And this is a wellness metric which is being provided in the Frontier X2 device. It is not meant for any medical or diagnostic purpose and is not being provided in the Frontier X Plus device, just to clarify. But yeah, thanks for that question. Actually,
we do exclusively cardiopulmonary exercise tests here for our athletes, and a lot of my patients will, have their Garmin or have their wearable of choice and try to correlate. And we actually, in my training, tried to look at whether there's any relation in wearables and our lab VO2. Sometimes they were completely, I think was just coincidental, and oftentimes they just were not. So I always say, look at the trends. But certainly, like Manav, said, if you're looking for your real VO2, go to a lab.
Yeah. So we just briefly discussed the topic of how patients should treat their, how they should follow their treatment protocol, especially when they've had structural heart defects. Just want to come to a couple of questions that we have from our audience before we run out of time. We are kind of out of time. So can I first take one's permission to carry on for another 5 minutes or so?
Sure.
Yeah. So we have an anonymous attendee who said that they had a mitral valve repair in 2024 and they were put on metoprolol. They then got an implant, I'm guessing an ILR, and over time developed PVCs. First 10%, then with more metoprolol, it increased to 20%. With further metoprolol, it increased to 30%. Then they decided to reduce the metoprolol, which resulted in a major drop in the percentage of PVCs. And then they stopped the medication altogether and the PVCs were gone. The question is, do some patients have adverse reactions to beta blockers? And also I'll add an adjoining question to that, which is related to Brian's history, which is that, is there a particular burden of PVCs that people should look out for and which could indicate bigger problems waiting in the wings? Let's turn over to Dr. Singh.
So usually we use beta blockers like metoprolol to suppress PVCs. So I'm surprised to hear that PVCs were associated with the use of beta blockers. So I think it depends on the origin of the PVCs, what the heart rate was at the time, what the structure of the mitral valve was at the time. So that might be related. So it may not be a direct causal relationship to the beta blocker. I haven't heard of that, but there may be other factors. Then regarding PVC burden, that's very important. We track PVC burden very carefully because a high percentage of PVCs can be related to the onset of cardiomyopathy and heart failure. And generally that cut point is 20%, but it's not an absolute cut point. I've seen patients with a PVC burden of 10% or less even get cardiomyopathy, and you would cure the PVCs and the cardiomyopathy resolves. So we know it's attributable to the PVCs. And sometimes patients with a PVC burden of 50% don't get a cardiomyopathy over time. So it's not a one-to-one relationship. The other important feature about monitoring is that when we see different morphologies of PVCs in a patient with cardiomyopathy, then we think cardiomyopathy comes first and generates the PVC. So that is helpful. That is helpful.
Dr. Singh, you want to add anything to this? And especially with respect to VT, we've had this question from several people who've experienced VT during exercise. That is it correlated with PVC burden, or is there, I mean, can a higher normal PVC be a precursor to VT or other kinds of arrhythmias?
I mean, I think it's possible. Oftentimes we might see just isolated PVCs, but no actual, manifestation of ventricular couplets and triplets and non-sustained to sustained VT. But really, as Dr. Varma alluded to, it's what I tend to look at is what is the true burden of PVCs over time. What does it look like with exercise? Because again, if I see, isolated PVCs transgress into some non-sustained episodes of VT and certainly a sustained VT, that to me is going to be, abnormal and something that we need to do downstream testing for, typically advanced imaging, consideration of coronary investigation, depending upon the age of the athlete. So in my book, unless it's truly non-specific, non-sustained, imaging is normal, there's absolutely no familial propensity for any underlying cardiomyopathy. There's very few cases where I'll say these isolated episodes are non-specific and non-sustained and nothing to worry about. And again, I will say, not all, PVCs or non-sustained VT are related to structural and functional abnormalities. Things like caffeine, pre-workout, anything that can really increase your sympathetic surge, those things can generate PVCs. I even saw, during the COVID pandemic with post-COVID syndrome, some people developed a lot of PVCs and increased sensitivity to PVCs in the absence of structural and functional abnormalities. So electrical disturbances, right? You're dehydrated during a race. It's a long, high intensity. Those things can also certainly manifest PVCs. So there's certainly kind of our non-cardiac causes and our cardiac causes. So we do just get a good history and then figure out what we need to do from there.
Thank you. So with that, I think we'll call it a day. Once again, this webinar was organized for the occasion of World Heart Day, which is the 29th of September. And it was to further our mission as a company, which is to help people live longer and healthier lives. And I hope everyone got something useful out of this. In particular, I would really like to thank Dr. Niraj Varma, Dr. Tamanna Singh, and of course, Ron, David, and Brian for joining. And Dr. Varma and Dr. Singh have real patients with life-threatening issues waiting for them. So I will not keep them any longer, and I won't keep the rest of you any longer as well. Once again, thank you very much for your valuable time.